Well, I'll start off by saying thank you very, very much to our panelists for arranging all of this tonight. And thank you to all of our participants for joining us this evening from across the country. So, tonight we're going to be talking about postpartum hemorrhage, targeted clinical pearls in obstetrical care. I think we can swap to the next slide. And just as a reminder that the webinar will be recorded and there'll be information provided of how other people can access it at a later date. This is the list of our panelists. So we've got Dr. Stephanie Cooper, Dr. Nick Papalia, myself as the moderator, Dr. Ari Sanders, Dr. Michael Secter, and Dr. Rob Thompson. And educational funding for this initiative has been provided by Ferring Pharmaceuticals. And we have the fabulous Erin Peterson, who's provided webinar production for us tonight, and we're very thankful. This is our agenda for the evening. So Dr. Cooper is going to start off with an introduction and get into her part of the presentation. We're then going to hear from Dr. Rob Thompson, and then Dr. Secter and Dr. Sanders are going to give us their talk on postpartum hemorrhage, surgical management, and review of the placenta accretum spectrum disorder, with what Dr. Secter referred to as the best clinical and surgical video he has ever seen. So I'm stoked for that. And then finishing off with Dr. Nick Papalia on iron deficiency in pregnancy. And in terms of questions for this evening, in the Q&A, I'll ask that everyone provides the questions in the Q&A portion. I'm going to assemble the questions as our discussion rolls today, and I'll make sure that they're addressed in the panel discussion at the end. Thanks, everyone, and I'll turn it over to Dr. Cooper.
Hi, thanks everybody for joining. What we want to do tonight is to really just have more of a focus on short snappers, clinical pearls. So, you know, any of these talks could be an hour presentation, I'm sure, but we really just want to get to sort of the nitty-gritties about postpartum hemorrhage. And you may recognize much of our team from our Critical Care in COVID podcast last spring. We have added some people such as Dr. Sanders, Dr. Rozenek, and we've lost some members such as our internal medicine friends, as well as Dr. Secter's mustache. So, so without further ado, I know a lot of people have already heard my presentation before. So Erin, if you just want to skip ahead 2 slides. Again, so I'm not going to go to all the details of the PPH project that we started in Calgary and the background, because I think a lot of you would have already heard about that so far, but really focus a little bit more on the practical, including how we do quantitative blood loss. Next slide. So, you know, I don't think I need to tell anybody that obstetric hemorrhage can be very severe. It is the most common serious complication of childbirth and the leading cause of maternal mortality around the world. But it's the most preventable cause of maternal mortality. So that means that our action can actually save moms' lives. Next slide. Again, if you've seen this presentation before, it's, I've said this before, is that, you know, postpartum hemorrhage is increasing in Canada. And next slide. And if we actually look at the causes, though, it's not just due to things like invasive placentation, which Dr. Secter and Sanders will talk about, but atony, which again means that management of the 3rd stage of labor can be a focus so that we can actually improve morbidity and mortality for pregnant women and new moms. New paragraph. Too much dictating. But the trend in Canada is not isolated to Canada. Certainly significant increases in postpartum hemorrhage also identified in the United States. And next slide. And also around the world in high resource countries. And this is again from Switzerland. Next slide. And what we have been able to understand from large quality assurance programs such as the Embrace in the UK and Ireland is that when we look at causes of moms dying from hemorrhage, the reason seemed to be in the majority of women because the severity of hemorrhage was not recognized. So basically, inability to recognize the seriousness and the amount of blood that a woman lost resulted in a delay in management. New slide. And I think it's important because for most of us, you know, having a mom die in childbirth is something that they haven't experienced or would be a very rare situation. And maybe hopefully you can only have a memory of, you know, a couple of cases in your career. But we have to remember that, you know, significant hemorrhage can lead to moms dying. And certainly what we're starting to also recognize that in our high resource countries is that women are dying from preventable causes of complications in childbirth. And this is an interesting trend that's been recognized in the United States of increasing maternal mortality. However, if you look at the blue line, that's California. And I'm going to get to California a little bit further on. Next slide. So because of the recognition of increasing postpartum hemorrhage, as well as other causes of maternal severe morbidity and mortality, in the United States, they developed a multidisciplinary organization that looked at improving safety in childbirth. Next paragraph, or next paragraph again, oh my gosh, sorry guys. Next slide. And they found pretty much what the UK did as well. That really most of the deaths were preventable, and it was due to lack of appropriate attention to the signs of hemorrhage and failure to restore blood volume to act decisively with life-saving interventions. Next slide. So you probably heard of safety bundles before. This concept exists for other areas of medicine. And what this is not new guidelines, but basically sets of clear evidence-based practices that when performed consistently improve outcomes. Next slide. And the Council on Patient Safety in Women's Healthcare developed safety bundles for postpartum hemorrhage, and based on different stages of organizational change. And I'm not going to go through all of them, but I have highlighted, again, what we've really adopted and what has made a significant difference is the assessment of hemorrhage risk and measurement of cumulative blood loss. And it doesn't mean that every center has to develop and take on all of these items, but certainly even some of them can make a difference, has been shown in some studies looking at this. And next slide. So back to California. California decided it was tired of women bleeding to death, and they have this, next slide, sorry. They have a very large, wonderful organization called the California Maternal Quality Care Collaborative. It's a lot of C's and Q's, and I never get it right. But they went a step further, which is to take those safety bundles and make them into toolkits. So basically very practical things that you can adopt for your center that incorporate those safety bundles for obstetrical hemorrhage. Next paragraph, or next. Okay, you guys can all laugh at me out loud when I do it again. And certainly we sort of did this at the foothills as well in Calgary, where we put together our toolkit with a safety bundle and made some very impressive documents that I cannot really take credit for because this was a team approach with our nurses at the foothills. Next, please. And so not to go through the project again, but basically we took a lot, you know, similar to what the US was doing, saying that we're going to identify hemorrhage risk for every woman. We are going to classify postpartum hemorrhage by stage. And we are also going to have a program of universally measuring blood loss quantitatively for every woman in labor and having a cesarean section, and use stage-based check sheets. Next slide. So this is Dr. Papalia. As you can see, he looks so tired. This is not a real patient, by the way. And you might also know, if you look up in the corner, there's Dr. Rozenek with her doll babies as part of a sim that we were doing. What we know is that early recognition of hemorrhage can lead to a more aggressive and appropriate response. So next slide. So we developed a risk assessment that basically categorizes women when they come in labor, but also that can be modified and changed as the labor progresses. That puts them into a category of low risk or medium risk or high risk. And with that comes a check sheet of what those risks would be and what action should result based on what category they're in. So for example, if they're a low risk patient, we just have, universal vigilance, as we should for all patients, as well as active management of the third stage. Now, if we get a very scary patient, which hopefully is in the hands of Dr. Secter and Sanders and not me, where we have a placenta precreta, then certainly how we're going to manage those are going to be very different with, blood work and consultations and whatnot. Next slide. Very important is the early recognition and management of postpartum hemorrhage by stage. And I've underlined the cumulative quantitative blood loss. And of course, then using the stage-based check sheets. And we'll go ahead, one. So I'm going to go to the stage-based check sheets to start. So Rob Thompson's going to talk a little bit more about the red that you see at the bottom, the stage 3 postpartum hemorrhage. And these classifications on stage is based on both the actual blood loss as well as clinical symptoms and signs, recognizing that healthy women often don't show clinical signs until they've lost a significant amount of blood. And also not relying on a hemoglobin to decide if you need to transfuse a mom or to be more aggressive with your treatment. But in order to actually have, to be able to classify according to stage, we actually have to know how much blood she has actually lost. And that's the importance of that quantitative blood loss. And next slide. This isn't a fantastic paper if you're a nerd like me who likes to read about hemorrhage. And Elliot Main is part of the California Collaborative, the first author on this paper. And based on that group that I talked about earlier, that is focused on maternal safety. And one of the things that he says in this article is very much apparent as we brought our project forward, is that there is a universal near tendency to underestimate blood loss at birth. Next slide. Those are my shoes after a C-section about 2 weeks ago. And everybody has used the term EBL, right? It's what's your estimated blood loss. It's something that we dictate in our C-section reports. It's what we write on our delivery notes. But what has been shown is that imprecise provider estimation, I'm quoting from this article, estimate of actual blood is a leading driver of delayed management. So again, we know that not recognizing the amount of hemorrhage was one of the main reasons why women were dying in childbirth from hemorrhage. And part of that was because everybody was underestimating blood loss. And in fact, studies have shown that it's anywhere between 30 to 50%. And depending on who it is, as I've done my little experiment of actually trying this, at work, that sometimes it's even more than that. Next slide. So here's our audience question. So what is your estimated blood loss based on this picture? So 450 cc's, 600, 1,000, or 1,300. And you can complete the little survey. And some people would have already heard my presentation at Ontario SOGC last week and already knows the answer. I will give you a sec to do that. Okay, and it looks like the majority of people say about 1,000 mils and nobody said 450, which is good. And some people, 37% said 1,300 cc's. Okay, so I'm going to go to the next slide, and you're going to get the answer in 2 secs. Okay, so cumulative actual blood loss, we call it QBL because CQBL would be too complicated. What this means is that you use careful, direct, and accurate measurements of blood loss. And also that you keep a cumulative record of blood loss throughout the birthing process. And it's important when you actually have a postpartum hemorrhage that not only are you recording and measuring, but you're also telling the care providing team how much blood has been lost so that it will hopefully drive recognition of what stage the hemorrhage is and when to escalate management. Next slide. In order to do that, you need, I guess, two main components that we adopted and is recommended by the consensus statement is to weigh blood soaked sponges and items and clots. And by doing that, you do need to have scales, which was a bit of a bump along the road because they do obviously cost money. And then a recognition of what the dry weight of these materials are. So if a sponge is, 25 grams and, or, 20 grams, and then you add, so much blood that you can then subtract. So having a calculator as well, and then a chart where you can actually physically chart that to keep track of everything. Ideally, if you have electronic medical record that allows you to do that, real time, that would be best case scenario. And the next slide. The other second component that's really important is the use of transparent calibrated under buttock drapes for vaginal deliveries. And hopefully everybody has clear calibrated canisters for C-sections. And why this is so important for vaginal delivery. And one of the things I recognized is how often we miss the woman progressing to a more severe stage of postpartum hemorrhage is because we're so focused on what's happening at her perineum that we're not recognizing how much blood is like falling onto the floor and going into the bucket by our feet. And so what this is, again, is a visual recognition and a way to measure blood loss and allows for that earlier and more aggressive approach to management of postpartum hemorrhage. And next slide. So here we go. Here's the answer to your question. So those are my feet. And if you look, that's not what's on the floor is actually a blanket. So the blanket was 740 grams. The blanket and blood was 2,100 grams. So blood was 1,360 mils. So the answer was 1,300 for the 37% who got it right. Congratulations. I get the question a lot about, when it comes to vaginal deliveries with the clear drapes, how do you separate from amniotic fluid? So the way that the drapes work is that there's sort of a bit of a wire on it so that you don't actually pull it out and start to collect blood until after the baby has already delivered. And at which point all the amniotic fluid would have come out. And similarly, when you have a C-section, we're actually looking as we deliver the baby and whatnot. So to the point where the baby's out and the placenta is not yet out or about to come out, that's when we actually say, okay, well, we have in the canister, we have 200 mils of amniotic fluid. So any additional fluids going into that canister now is blood or mostly blood. And next slide. So in terms of stage management, and the rest I'm not going to run through in detail, and these documents will be available as well. Next slide. We recognize that check sheets are really important to perform because performing critical tasks each way reduces human error, and they can reduce harm and improve outcomes in medical care and obstetrics. Next slide. And so we have these that we created. And again, you don't need to have the same one that we have, but for each stage. So, and certain things like, making sure the patient is supine or giving certain medications. And next slide. We're gonna go through these ones pretty quickly. So stage 2 PPH, we're escalating management, in our center where we want to call our second obstetrician to be available, both to manage the floor as well as in case we need to go to surgical. And you'll see down there as well, it's the assess, document, and report vital signs to the team every 5 minutes, and weighing, measure, and calculating and reporting the cumulative blood loss every 15 minutes or sooner as needed. Next slide. The stage 3 management, I'll leave to Dr. Thompson, and next. And important also as well, because in obstetrical and any emergency, it's really important so that you have clarity of communication. And so being able to develop an understanding before an emergency happens of what everybody's role and responsibilities are in an emergency. Next slide. So I'm just gonna, again, we can just sort of scroll through these pretty quick, Erin. So, important, of course, always to debrief after every significant postpartum hemorrhage to learn and improve. Next slide. We have a sample debriefing form that we'll make available as well. And next slide. And of course, using simulations and drills to keep those practices up to speed, and especially the more rare an emergency is, or if you're at a center where you may not get as many complicated pregnancies where, you know, a significant hemorrhage would be unusual, that you really should practice with your team. Next slide. And then, of course, to review and report adverse events so that, you know, other people can learn from what went wrong in the system. Again, away from this shame blame approach where it's somebody's fault or somebody should have done something better. It's recognizing that, you know, what are system situations, you know, that could be improved, because if it can happen to, you know, in one case, it can happen in another case. And by recognizing where things went wrong, we can then change to improve things for a future case. Next. So, you know, I get this, you know, this is a lot of work. You know, we don't want to do this. Does it really make a difference? Next slide. And you'll recognize, as I said earlier, I mentioned California, and they developed basically a program just like this, and they found a significant decrease in near deaths from maternal bleeding in the first year. So 21% decrease in the hospitals that adopted the program versus 1.2 in those that didn't. Next. And as you can see, and California then went on to develop toolkits and safety bundles and use them through the collaborative in not all of their hospitals in the state, but California comprises, they have 10% of all the deliveries in the United States. So it's significant. And as you can see, look what happened to their maternal mortality rate as a result. They completely bucked the trend that's happening in the rest of the United States. Next slide. We're just gonna move ahead. And we had great feedback from our frontline workers who at first were hesitant, but now are really all on board. Next slide. So I'm just going to end there and move on to our next speakers. But I really want to just drive home that, you know, you can do this in your centers. Postpartum hemorrhage is the most preventable cause of maternal mortality and also severe morbidity. We've shown that locally in terms of outcomes already at our center. Recognize the problem, don't delay treatment, and really just have that systematic approach that you can adopt for your centers. Okay, so I'm just gonna end there. And there's a little bit of a feedback that I can't give my own feedback, unfortunately. And then I am going to move to Dr. Thompson, and Ariela, you're on, I think, again. Thanks, everybody.
I was just gonna say Dr. Thompson is next, that's all.
Okay, perfect. I've been asked to talk about this. I'd like to thank everyone again for being here today. So just to start off with some medication strategies. Next slide. We're going to discuss the importance of prevention because I think it goes without saying this is one of the largest things that we can do. Review the role of cell salvage in obstetrics because it is controversial, and then review some of the medications that can be used in PPH. Next slide. So by far the most common cause of PPH is urinary. However, it's not the only cause. So it's important to diagnose the problem early and treat appropriately while not fixating on one cause and having a clear understanding of who's at risk. And Stephanie talked about that with having patients evaluated for their risk factors. It should lead to a higher vigilance and preparation in these patients, but certainly all women should receive active management of the third stage of labor. And this is shown to decrease atony by 40%. With the increased utilization of delayed cord clamping, drugs have arguably become the most important part of active management and likely the most efficacious. Currently, drugs available are oxytocin, carbetocin, ergonidine, and misoprostol. These meds all pose their own challenges with side effects, contraindications, and issues with storage and administration. Next slide. After the recently done Champion trial, which looked at over 30,000 women around the world, the WHO updated its treatment guidelines for the active management of the third stage of labor. And really in developed countries, you kind of look at the bottom of the list. And currently in Canada, the two most available drugs that would be used in this are oxytocin or carbetocin. One of the problems with carbetocin before was that it was not heat stable, but with the new heat stable formulation, it's obviously much less of a hassle to store now than it used to be. In our site, we tend to use, according to the SOGC guidelines, we follow those where it's been shown to be beneficial in patients at risk for PPH with vaginal delivery. So we're starting to do that. And then with all of our C-sections, it reduces the need for a transfusion of oxytocin later, and treating these patients earlier prevents PPH later. Next slide. So cell salvage, well, it's well proven in other disciplines. The benefits are that there's a higher oxygen transport and viability than banked blood. It's normothermic. There's a lower potassium load. It's useful in patients with Jehovah's Witness that will accept it. And it's useful in patients with rare blood types or significant antibodies. And you avoid some of the complications of allogeneic transfusion. It also doesn't affect clotting if you stay under 3 liters and doesn't increase the rate of platelet or FFP transfusion. The cost appears to be reasonable if there's large blood loss. So most of the studies have shown greater than 2 units. It is reasonable. And the cost is not ridiculous. To have it set up for standby in cases that you're worried about is comparable to reagents for cross-matching 2 units of blood, which is around $85 in Canada. Next slide. So most of the evidence prior was related to case series and reports, and there was big concerns with amniotic fluid embolism when using this in pregnancy. In Europe, they did a study called the Salvo trial, which was looking at using it in all patients for C-section that was considered higher risk for PPH. Now, this obviously turned out not to be economically viable as the number needed to treat was quite high. You needed to treat 100 patients for one benefit. However, what it did show was that it was safe to use in pregnancy, and there was no amniotic fluid embolisms in this study, and there was over 3,000 patients. So what the current evidence would suggest is that it is safe to use. There is isoimmunization, so RhoGAM may be needed depending on the clinical context, but it is safe. It is better to be used in centers that have experience using it because it does become more effective with more use, using the suction appropriately and getting more red cells back when you're using it. Now, there are some contraindications to it, such as sickle cell, thalassemia, malignancy, and clotting agents. Next slide. So moving on to the medications, next slide. Carbaprost is a synthetic prostaglandin analog of PGF2 alpha, and this increases myometrium-free calcium concentration, enhancing uterine contractility. The big drawback of this one is the side effects. It's got a relatively high rate of nausea and vomiting, diarrhea, flushing, mildly increased blood pressure, and certainly bronchospasm, which is only relatively true in contraindication would be asthma. Most patients respond somewhat with a single dose. However, in most studies, to get a 90% response rate, you'd need at least a couple of doses. And given its peak takes 20 minutes, this does also take a bit of time to work, and you want to be having things work quickly. So this wouldn't typically be the first agent that we would use at our site. Next slide. Ergonavine or methylergonavine maleate is a semi-synthetic amine ergot derivative. It's important to store this properly. It should be stored away from light, heat, and humidity because it's quite unstable, and it should only be given if it's clear and colorless. The mechanism of action is actually unclear, although it's a serotonergic receptor agonist in smooth muscle, a weak dopaminergic antagonist, and a partial alpha agonist. It's thought to work either through its serotonin or alpha adrenergic receptors causing calcium influx. When compared to carbaprost, it's associated with less hemorrhage-related morbidity after oxytocin failure. Now, it's not recommended IV because of the risk for significant side effects with stroke and cardiovascular myocardial infarction. And this was an FDA warning several years ago. However, back in 2012, they actually stepped back this warning, saying that the risk was actually quite overstated And the reason for that is it used to be recommended to be given intrauterine, and with the increased vascularity, it was essentially the same as giving it IV. This drug works quite quickly, even giving IM, so there's really no reason to give it IV. And its onset, as I said, is quite quick. And the side effect profile is actually quite low. There's obviously contraindications. Hypertensive patients are relatively contraindicated, preeclamptics, obviously. And then HIV protease inhibitors and non-nucleoside reverse transcriptase inhibitors have issues with the CYP3A4 inhibitor system. So it should be used in caution with HIV patients, depending on what medications they're on. And this is certainly the drug that I would move to next after I had failure of carbetocin or oxytocin. Next slide. Misoprostol is really not an agent that's of much use once you're past the active management of the third stage of labor, and arguably in a place like Canada, we should be using things like carbetocin or oxytocin. And in my opinion, this just doesn't have much of a role in an end-stage PPH if you have access to other medications. Next slide. So tranexamic acid. This has been a great development. It's a synthetic lysine analog that is an antifibrinolytic that competitively binds to sites on plasminogen to prevent the enzymatic breakdown of fibrinogen and fibrin. It peaks immediately and has a half-life of about 2 hours. It's very inexpensive. So during placental delivery, you get a rapid degradation of fibrinogen and fibrin, as well as activation of plasminogen activators and fibrin degradation products as a result. And this can last 6 to 10 hours postpartum that can lead to more hemorrhage. And as you can see, tranexamic acid interferes with this process and helps us stabilize clots. So trauma studies showed initial very positive outcomes with the CRASH-2 trial with decreased morbidity from bleeding. However, there was still concern because of venous thromboembolism. Sorry, next slide. So there was still concern, and then the women trial came along, which alleviated those concerns. There was no increased risk of venous thromboembolism in this very large study, which showed it was very safe to use. However, it does need to be used quickly to have effect. And that makes sense with its method of action, or mechanism of action, sorry. If it's given within the first 3 hours, it will decrease death due to bleeding. However, the woman trial did show, and this would be consistent with trauma literature, that if it's given too late, it's actually harmful. So the doses that are suggested to be given, next slide, are 1 gram or 10 milligrams per kilogram. A second dose can be given within 30 minutes if it doesn't seem to be effective. And then if there's rebleeding, it can be given within the first 24 hours. And the bottom line is it doesn't harm, and it likely gives substantial benefit, and we've seen that. It's also important to consider prophylactically. The Royal College of Obstetrics and Gynecology now suggests patients at higher risk for PPH should have it prophylactically, and we certainly give it to our invasive placenta patients and should be given as a first-line agent in postpartum hemorrhage. Next slide. So factor 7A sounds like one of the big guns. It actually works by binding to tissue factor and initiating coagulation, and small amounts of thrombin are created. At pharmacological doses, it activates factor 10 on the surface of activated platelets, and you get a thrombin burst. So much more profound effect of platelet plug. And this leads to a stable hemostatic plug, which controls the bleeding. Next slide. So this sounds great. And there was promise in early case reports, but it was just that, case reports. It does the prevention of bleeding make up for the risks? And there's significant risks with it. When it's been looked at, there's really no survival benefit. And there's an increased risk of arterial thrombosis. So it's still only used in study circumstances now, or as a Hail Mary third-line treatment. It's not recommended as routine practice by any of the guidelines. But if you're not getting anywhere, there's significant bleeding, you've got to remember, for it to be useful at all, the patient has to be stabilized in other ways, such as they have to be euthermic. The acidosis has to be treated. They have to have reasonable fibrin levels to be able to cause that fibrin burst. And then they need to have platelets to be able to have that platelet plug. Otherwise, it's essentially useless if those haven't been corrected. Next slide. So Riastap is one that I wanted to talk about as well, because I think it's quite important in these situations. Fibrinogen is the first coagulation factor diluted in a massive postpartum hemorrhage. There's roughly about 10 grams in an 80 kilogram person. It's only in the plasma, so it gets depleted quite quickly and bleeding. Typically use 1 gram per liter in non-pregnant patients as a threshold for treatment. However, in the pregnant state, the fibrinogen levels are higher, and you need to treat this earlier. And typically 2 grams in pregnancy would be a threshold that you would have to treat at. And it's actually a poor prognostic sign if your fibrinogen drops below too early. You're likely headed for a massive postpartum hemorrhage and should treat this aggressively. And it should be given early in large blood loss, even if your PT and PTT are within normal ranges, because these typically should be low normal. And if they are elevated, it's an ominous sign that should require aggressive treatment. If you don't know what the fibrinogen level is, they suggest a dose of 70 milligrams per kilogram to start with, or you can use the dosing guideline equation if you do have fibrinogen levels, which you should eventually get. Next slide. Just pulling something up here. So the next part I was going to talk about was management of stage 3 PPH. Next slide. So the goals in this part were to understand the pathophysiology of massive hemorrhage a little bit, look at the differences in obstetrical patients, take a look at some of the blood components that we'd be using, appreciate some of the complications that can happen, and develop an approach. Next slide. So hemostasis is obviously very basic. You get your platelet activation, vasoconstriction and platelet plug, thrombin activating fibrinogen, you get a blood clot through secondary hemostasis in your coagulation cascade. And once you have your clot, you have fibrinolysis and clot degradation. Next slide. So one of the problems is in a massive transfusion, you have this dangerous triad of acidosis, tissue hypoxia, and hypothermia, which leads to more coagulopathy, which leads to more bleeding. And you get in this vicious cycle where you start circling the drain in this DIC type situation based on natural bleeding, based on how our treatment is derived. And we want to avoid that and treat this early before it gets out of control. Next slide. So in pregnancy, you can best describe it as a chronic compensated DIC picture with a procoagulant bent. So the big takeaway here is that they're in a procoagulant state. PT and activated PTT levels may be normal despite a massive hemorrhage with dilutional coagulopathy, and if prolonged, are an ominous sign and should be aggressively treated. Next slide. So as Stephanie was saying, we typically underestimate bleeding considerably, and by about 30 to 50%. Visual is very inaccurate, but should be monitored and estimated. Charts or visual aids like this one can be helpful in assessing where bleeding is if you're not able to measure, but measuring and weighing if possible is better, and weighing sponges, mopping up blood off the floor and weighing it, drapes, suction, and making sure that you're tabulating that. Next slide. As bleeding happens, we need to be continually clinically assessing the patient, because this is going to be an evolving process. With increased circulating volume in pregnancy, signs of hypovolemic shock are much less sensitive, and patients are going to be much further down this list by the time they start showing signs. Younger patients have a much later drop in blood pressure, and really dropping blood pressure is an ominous sign in these patients. It's a useful tool to estimate the allowable blood loss using an equation of 70 mils per kilo for body water multiplied by their weight in kilos, multiplied by their initial versus their desired hemoglobin, divided by their initial hemoglobin, which gives you a guideline for the amount of bleeding where you're going to have to start replacing something and moving on from crystalloid. And that just gives you a starting point till you get some of your lab values back. Next slide. So what are the components that we give? Well, giving red cells is not just about the red cell component. And in a massively bleeding patient, this is different than the trick trial. You're not worried about being stingy and giving a restrictive strategy. There's rheologic properties with having enough red cells that actually increase the platelet concentration at the perimeter, where they can be exposed to damaged endothelium and trigger the clotting cascade. There's considerable evidence in animal, volunteer clinical models that you can decrease bleeding time after a transfusion of red cells in thrombocytopenic patients. It's still controversial, though, as to what the actual number is. Most guidelines suggest a goal of greater than 85. However, it's suggested that for sustained hemostasis, you actually require a hematocrit of 35%, which roughly equates to a hemoglobin of 105 to 115. And remember, these are a moving target. So as you're bleeding, what you give in isn't necessarily going to be where they're sitting. So you're going to have to historically be using the lab values you're getting, unless you're lucky enough to have point of care testing. In essence, the takeaway point is that don't be too slow to react. Next slide. So again, as I spoke about earlier, fibrinogen is the first coagulation factor that gets diluted in a massive postpartum hemorrhage. Early correction appears to be extremely important. A fall to 2 grams per liter or lower is an early prognostic sign for massive hemorrhage and poor outcome. So patients need this to be given. In our center, we have Rheostat. Other places, it would be cryoprecipitate. And most guidelines suggest a goal of greater than 2 grams per liter. It should be given early, even if the PT and PTT are normal, and then targeted goal therapy with your lab values should be followed. Next slide. So platelets. The bone marrow and spleen can release these into the circulation, so they tend to take more time to drop. However, once you've lost 2 blood volumes, most patients will be below 50 or at least down to 50. The goal is to have a platelet count of greater than 75, because again, once you give them, you're going to be losing some of them. Some of them are going to get activated, and this will maintain a level above 50, which is felt to be sufficient for reasonable platelet plug formation. There is a higher risk of complications with platelet transfusion, so this has to be kept in mind. They have the highest risk of trally and bacterial contamination because of the temperature that they're stored at. Some patients may be less responsive if they've had a prior transfusion, if it's ABO incompatible or RH incompatible. When you're administering it, it's important to remember microfilters shouldn't be used because they'll remove most of the platelets. There's less risk with ABO incompatible units, but people can still have reactions and consumption. Warmers are thought to activate, but it's controversial. Pressurizing does activate the platelets, so they cannot be given under pressure, and ROGAM may need to be given. Next slide. Question pulling up here, just to keep everybody interested, is what is false regarding the use of fresh frozen plasma in pregnant patients? Should it be given when APTT is greater than 1.5 times normal? It will paradoxically lower fibrinogen in the pregnant patient. It will lower plasma calcium levels. There's no risk of trally, or it can take longer to receive from the blood bank. I'll just give you a minute to answer this. Okay, and the correct answer here is the correct answer here is D, there's no risk of trally. There's actually a considerable risk of transfusion-associated lung injury with FFP. Next slide. So coagulation factors. If you have a bleeding patient and there's no lab results available, 15 mils per kilo of FFP should be started with continued bleeding. Now, I'm not talking about you've only given 1 or 2 units of red cells. This is when you're getting up to 4 units or greater. You've got continual bleeding, especially in a pregnant patient. This is extremely important to stay on top of this because they will get a dilutional coagulopathy as you continue to give them fluid and treat their bleeding. It should also be considered early in high-risk situations such as delayed postpartum hemorrhage, abruption, or potential amniotic fluid embolism. And again, it should be goal-directed therapy following your PT and EPTT. And again, if you're lucky enough to have point-of-care testing, that's fabulous, and follow those results. And again, order it early because it has to thaw. So it can take up to 30 minutes to get from the blood bank. Next slide. So one of the things we have to consider too is how much of each product do we give as we have this ongoing exsanguination. Ratios originated in the military setting. Early studies showed a massive survival benefit with patients getting a lower ratio of plasma and platelets to red cells. And this was whole blood essentially, but it was fresh, so there was a bit of bias. There were a couple of trials that came out later looking at this in trauma patients, which showed better hemostasis. The ratio hasn't been determined, and there's no good trials in obstetrical patients. So we do extrapolate from the trauma literature. And it would suggest that lower ratios are better for patients. When you look at the European guidelines, they suggest a 1 to 2 ratio in massive hemorrhage. But again, to avoid a more minor bleeding, and that's because platelets and FFP come with more complications than simple red cell transfusions and aren't necessary if there's a smaller amount of blood. But once you get into larger volumes, it becomes more important. Our current guidelines at our center would be a 1 to 2 ratio with FFP to platelets to red cells. Next slide. So we also have to consider other things when ongoing hemorrhage is happening, and hypocalcemia is very common in a massive transfusion. The citrate binds calcium and lowers levels of the ionized fraction. And this is much more significant in platelets and FFP. And this is essential for coagulation. It's also essential for cardiac contractility and systemic vascular resistance. So it does need to be maintained at least at 1 millimole per liter so that you don't have complications from hypocalcemia. Next slide. Potassium is the other major electrolyte to keep an eye on during transfusions. The older the blood is, the higher that concentration of potassium is going to be, and rapid administration of cold blood can actually mimic cardioplegia in a small patient, and certainly cardiac and renal patients are at higher risk of having complications from hypercalcemia, and acidosis in an ongoing bleeding patient will exacerbate this. Now, paradoxically, hypokalemia is actually more common now. As we aggressively treat hyperkalemia, you get reentry of transfused red blood cells, and you get an alkalosis as your citrate is metabolized to bicarb and a stress hormone response. So the big picture is you need to be monitoring these as the bleeding is continuing. Next slide. One of the biggest things to consider too, and I can't emphasize this enough, is hypothermia causes a significant coagulopathy, and this needs to be managed throughout a resuscitation. Radiant heat loss is one of the largest sources, so room temperature should be increased. There should be a forced air warmer if they are available, and very importantly, blood is cold, very cold, so it needs to be warmed as it's going in. Obviously not the platelets as we talked about, but all the other fluids going into the patient should be warmed, as hypothermia will cause a progressive coagulopathy. Next slide. Dissolved oxygen only becomes important at very low levels of hemoglobin, but this can be important in Jehovah's Witness patients or massive blood loss. And certainly, once you've transfused a lot of blood, airway pressures and ventilation may become a concern if you cause fluid overload or there's a transfusion-associated lung injury. So it's important to have oxygen on these patients. And transfused blood doesn't have as good of an oxygen carrying capacity. Acidosis affects the release of oxygen to the tissue. So aiding with more oxygen helps patients in these situations. Next slide. Again, medications that we talked about already are important to use. Tranexamic acid early, uterotonics early if there's atony, and using different agents. Don't keep running oxytocin in a bag if you've already given carbetocin or oxytocin and there's no effect. Clearly the receptors are maxed out and you need to use another medication to help affect the uterus. And then Riostab early so that you're replacing their fibrinogen levels. The other thing to consider too is as you get to certain levels of bleeding, you're going to start dropping the level of the medication that's in the blood as you're washing it out with transfused blood, depending on the level of bleeding. So you need to consider how much bleeding has happened, whether you need to redose these medications to get enough at the effect site. Next slide. So again, with anything, you need a massive transfusion protocol. There's a lot of stuff going on here. You need a way of activating it and deactivating it. You need communication between the patient area and the blood bank because there's a lot of things you need to ask for. You may need help dosing the Riostab. You need to let them know that you need a certain amount of FFP or that you're going to need more at some point. Consistent blood component packs so you know what's coming. Disposition of unused products so you're not wasting blood products that aren't used. Activation of adjunct therapies. So you need to know where your postpartum hemorrhage kit is with drugs. You need to give tranexamic acid. When Riostab comes up, it's extremely difficult to mix because it foams up quite readily. So it's got to be mixed quite carefully. So there's a lot of people that need to be doing these roles. Consistent and timely lab tests so that you have something to follow and a historical trend to look back on to see where you're at and where you're probably going. Or again, if you have point of care testing, even better, you can follow that and immediately act on it. And then ongoing audits of your protocol to see if it's being followed properly. Next slide. So having a checklist is also important. So simple things like raising their legs to help with venous return until you've got adequate access, administering oxygen, getting adequate access. So you don't need a central line. You need large bore IVs to give fluid quickly. You need warmers. You need pressurizers, whether that be bags or an actual level 1 pump. You need to talk to transfusion medicine. This is a very COVID unfriendly situation. It's a party. You need to bring people. You need to help with people checking blood, getting medications ready, checking the patient's vital signs, getting access. This isn't a single individual job. There are lots of roles that need to be filled. You need to monitor the patient. Arterial monitoring is important, but it's only important after you get access so that you can give fluid. Obviously, a Foley catheter. Consider cell salvage if you think there's going to be a lot of ongoing bleeding so you can minimize some of the allogeneic blood you're giving. Send baseline blood work and then follow it. Reverse any systemic anticoagulation like heparinization or warfarin and treat any causes. Is there any tissue left behind? Is there uterus atonic? Is salvage surgery an option, which Dr. Secter is going to talk about later? Actively warm the patient and monitor that temperature, and then change the filter regularly with the blood, otherwise it'll clog at some point. And then consider drugs, calcium administration, TXA, and then bicarb or THAM if they're acidotic. Consider aortic compression if you fall way behind, because at a certain point, if you fall way behind, you just have to catch up, and that may be necessary. Depending on the skills and where you are, that may not be possible, but it certainly would allow you to catch back up in a dire situation where you've fallen completely behind. And then at the end, their disposition. Do they need to go to the ICU or a higher monitored area? Inform transfusion medicine that you're done with the process because they have other things they need to do as well. And then wait. Rebleeding can happen. So if you leave the area of treatment too quickly, you may just be running back, or you may be later to be aware that they are bleeding. Next slide. The big key points to this is in pregnancy and a postpartum hemorrhage, early aggressive treatment saves lives. It's a multidisciplinary event. You need lots of people and lots of help. Low ratio blood component therapy is useful in massive transfusions. So we're talking more than 4 units. Under 4 units, you're unlikely to need these extra products. It needs to be goal directed. All these guidelines are just guidelines. You need to follow what's happening with your patient as to how much fibrinogen they need, how much platelets, because it depends on what they're starting with. Maintaining normal physiology. If they're hypothermic and they're acidotic, all your treatments aren't going to help. And then obviously preparation, training, and review is required so that you know all these processes are happening properly. I think after that, I can switch over to the next speaker. Thank you.
That's me. Thanks, Dr. Thompson. Excellent talk. So I was asked to speak briefly about surgical options in postpartum hemorrhage. And really the goal of this talk was clinical based and not really a synthesis of evidence. It's to provide our guests for useful tips and tricks and techniques in the management of severe postpartum hemorrhage requiring surgical intervention. Would like to say hello to everybody from across the country. It's nice to see a lot of you. And I have Dr. Ari Sanders with me, who is also a minimally invasive surgeon and also on the invasive placenta team with myself in Calgary. And so he might be able to do some of the Q&A if you have questions that come up during the talk. So we'll start with the next slide, please. So our only disclosure is that I'm a speaker for Bayer Women's Health. And as much as we like to operate together, we also like to ski together, which is one of the perks of working in Calgary. Next slide, please. So as I mentioned, the goals of today's talk are to talk about really techniques and approaches in the management of severe postpartum hemorrhage requiring surgery. So one of the things that I'm going to show you is a contemporary approach to internal iliac ligation that we use here. And then I was also going to talk about some surgical pearls for the management of invasive placentas, and basically a review of what we are doing at this program here in Calgary. Next slide, please. So the question comes up very frequently: when do you actually need to do surgery? And I mean, I think that the most common time that you'd need surgical intervention is really severe uterine atony in the context of other failed conservative measures. So when you have run through your medications and your balloon tamponade, you may need to consider surgery. But there are other incidents where you need to plan for surgical intervention. So patients that have known arterial venous malformations, the rare uterine inversion, placenta previa is important to have tips and tricks. But then there's also the things you might find at surgery or at the time of a cesarean section, like deep surgical extensions into the uterine arteries or cervix or vagina, uterine rupture or vascular injury. I think the worst situation I've had is a detachment of the uterine artery from the iliac at basically where the cervix meets the vagina. And then, of course, what we're going to talk about towards the end of the talk, which is the placenta accreta spectrum. And that's a picture of a bivalve uterus where the placenta uterus was all one specimen that was, you couldn't differentiate between tissue planes. So next slide, please. So just as a brief overview, I think that ideally, this is sort of how I would progress through management and how I would suggest we offer these therapies. So the first line of therapy is usually a compressive balloon, and that doesn't have to be a Bakri, that can be a Foley, that can be a condom catheter, that can be a Roche catheter. But ultimately, compression is a conservative way of managing a bleed that is not responding to medication and should be considered as first line. Next step, if you do end up opening a patient, or if you're already open, then tourniquets, B-Lynch sutures, box or Cho sutures, as well as potentially uterine packing are good next steps. And so you start with a balloon, you move to compressive sutures, and if that's not working, it's time to consider vascular control of the uterus. And so a stepwise devascularization, whether that be through uterine artery ligation, uterovarian clipping or ligation, temporarily suppressing the blood supply from the IP, and then moving into internal iliac ligation. And one of the things that we want to talk about today is a video that Dr. Sanders made about contemporary approaches to this, which are a bit faster, a bit safer, and hopefully accessible to more people. Should that not work, you need to consider moving on to a peripartum hysterectomy. And we're going to talk about some of the steps involved in that. But that can be a major emergency, which requires a lot of personnel and activation of a backup system. Embolization is an important adjunct, but ideally it's not your first line of therapy. And really there are narrower indications for the use of embolization in a severe postpartum hemorrhage. Ideally, these are persistent, slow, but controlled bleeds. Patients who are completely hemodynamically stable, patients that are non-coagulopathic, and patients who have also failed other less invasive therapies. So next slide, please. So this is from the Green Top guidelines out of the UK, and I think this is a really nice slide and actually a great guideline to talk about. You know, when you have your unstable patient with heavy bleeding postpartum, you need to move to the theater and determine whether or not your uterus is contracted. Do you have retained products? Do you need to do a D&C? And have you done everything medically? Following that, you should move to balloon tamponade and then consider your compressive or brace sutures. If that's not successful, then you can move into your surgical interventions. We'll go to the next slide, please. So a few clinical pearls that I think are important. Number one, you call for help as early as possible. If you are a family doctor or midwifery, you should call for OB and OB backup. And if you think that there's a suspicion of invasive placentation, then the activation of your local team would be advisable if your site has one. Calling anesthesia and backup and getting nursing available who have experience with peripartum hysterectomy can be a really crucial part of getting through this seamlessly. I think it's also important to know where your equipment is, know where the hysterectomy kit is, know where the B-Lynch sutures are, know where the clips are, know how to work a backry. I think the more frequently that you simulate it and prepare for it, the faster it goes. I'm not going to go over maternal resuscitation, but I think that clear dialogue and communication with the anesthesia team is extremely critical. And if I could say the one thing that I think is the most important thing is decisive management. So if you think it's headed that way towards surgical intervention, you know, being clear, being decisive, and acting early, I think is a really critical piece. Next slide, please. So the question often comes up that if you are at a vaginal delivery and you need surgical intervention, how do you go about doing it? I mean, if you're already open at a cesarean section, obviously you have likely a phalansteal colon incision, but I think that if you're moving towards surgical intervention in a life-threatening emergency, midline laparotomy should be considered. The other thing that I tell all of our trainees is that if you're going that way, place the patients in lithotomy, and I think that there's a ton of benefits to that. The first one is obviously back replacement. You can go from the vagina to the abdomen or from the abdomen to the vagina. If you need to work on the bladder, dissect around there, retrofill it, you have great access. And if you are moving towards a hysterectomy, then fornix delineation with a Breisky retractor is way easier with a patient in lithotomy. I mean, of course, there's issues with setup time, draping, sterility, and potential nerve injury in a long case where you rush to place them, but I still think the pros outweigh the cons. Midline laparotomy offers superior exposure. It offers efficiency. It facilitates iliac ligations and hysterectomies in an emergency. But there are significant cons well beyond the cosmesis of it. I mean, the respiratory and infectious morbidity is substantial. Obviously, these patients are slower to mobilize. They have higher rates of surgical complication. But the other thing that I hear a lot about is junior residents not feeling as comfortable with midline laparotomies, which I usually talk them out of. It's an important skill to have, and we practice it when we need to. Next slide. So as I mentioned, the first line of therapy, well, before you have gone into surgery, should be a balloon tamponade. We use a backry balloon, which can generally be filled up to 500 cc's, left usually for 6 to 12 hours. Can be left longer in an emergency, but we do know that longer than 12-hour use is associated with more febrile morbidity. We do also know that a case series showed that this can potentially reduce the rate of hysterectomy by up to 90%. One of the other things that you encounter in the literature is something called the tamponade test, whereas if you have given all of your medications and you're managing postpartum hemorrhage and you put a balloon that is well and adequately placed inside the uterus and you are still bleeding despite it being activated, it's time to consider a laparotomy and escalating things. And I know that making the actual decision to commit to surgical intervention is hard, but this might be considered as one of the indications. Next slide, please. So the B-Lynch suture has been modified many times and there's many alternatives, but the biggest study of the B-Lynch suture showed that it might alleviate hysterectomy in 3/4 of the cases where it's used. This can be used in combination with a balloon tamponade, but you need to deflate the balloon before you do this, otherwise you could rupture it. I'm going to talk about the technique of it in a second, but it appears that there's actually minimal effect on future fertility. We do know that it can potentially cause, in rare cases, uterine ischemia, pyometria, or uterine synechia. And if you use a permanent suture or a delayed absorbable like a PDS, you can risk bowel herniation through those suture placements. There are case reports also of risk of future invasive placentation, but in general, it's a highly effective technique. Two things that are evidence-based is you should keep a laminated sheet of the technique close to the OR, and you should use a large Mayo needle, number 1 or number 2 of chromic or Vicryl. So next slide, please. So this is the technique. You come under the hysterotomy through over the top of the uterus, suture across the back, come back, scrunch it and tie it in front. There are some incredible videos online that would show you how to do it in a stepwise fashion that I can refer you to. And these are the 2 sutures that you want to look at. Very large 70mm needles with number 1 suture. The Cho sutures and the Heyman sutures are other techniques if there's no hysterotomy that was made. So next slide, please. So if that's not working, you need to consider devascularization. And the first one is a uterine artery stitch. There are a lot of different techniques to do this. The one that I talk to our trainees about is transection and early sacrifice of the round ligament, which helps drop the bladder inferiorly. And then I oftentimes will make a window in the broad ligament to actually isolate the uterine artery and then use a large Vicryl suture to suture ligate that. You do that bilaterally, and it goes without saying that the easiest way to do this is with exteriorization of the uterus if possible. Ligation of the uterovarians, you need to be careful because if you are not, you can get the fallopian tube, which can be problematic. So a way of doing this is either with clips or clamps to avoid the venous plexus and damaging the fallopian tube at the same time. Next slide. So finally, the contemporary internal iliac ligation, I think, is an important technique. And you do have some prerequisites. You do need to have anatomical knowledge, experience, comfort around the ureter and in the retroperitoneum. And you need to know the complications: ureteric damage, external iliac vein, internal iliac vein damage. But if you do and you feel comfortable, I think it's a pretty important technique. It can decrease the pulse pressure by up to 85%, decrease the flow, and allow for clot formation. It's estimated that this too can decrease the risk of hysterectomy by 60%, and it does not appear to have a major impact on fertility outcomes. And we know that through both this literature and also our myomectomy literature. Next slide, please. So I wanted to show a video that was made through the Toronto program by Dr. Sanders when he was training there. I think this is one of the top videos around. It's the best I've ever seen. And Aaron, if you could play that for us, that would be great.
The pararectal space is bordered by the sacrum posteriorly, the internal iliac artery laterally, the cardinal ligament anteriorly, and the ureter medially. Step 3. Identify the anatomy. After dissecting the pararectal space, it is necessary to identify key anatomic structures. Here, you see the internal and external iliac arteries. The external iliac vein courses deep to the external iliac artery, just adjacent to the internal iliac artery. The ureter runs along the medial leaf of the broad ligament within the pararectal space. It can be seen vermiculating here. Step 4. Isolate the internal iliac artery. After identifying relevant landmarks, the internal iliac artery is isolated by dissecting away the surrounding connective tissue. We use a Lauer to help accomplish this. Note the proximity of the adjacent external iliac artery and vein. Care must be taken to avoid injury to these structures during the dissection. Step 5A, vessel ligation using the traditional suture ligation technique. During this technique, it is necessary to completely mobilize a portion of the internal iliac artery away from the adjacent structures in order to safely pass a ligature around it. Repeatedly identifying the anatomy is helpful in maintaining orientation and avoiding complications during this step. Once again, a Lauer is helpful in accomplishing this. Here, some of the vessels from the anterior division of the internal iliac artery can be visualized. The Lauer is used to mobilize the internal iliac artery away from its underlying vein. Utmost care is required when dissecting underneath the internal iliac artery to avoid damaging the internal iliac vein. The ureter can be observed vermiculating safely away from the operative field. The vessel is then grasped and elevated with a Russian forceps while a Lauer frees the vessel from the underlying structures. This is performed in a lateral to medial fashion to avoid injury to the adjacent external iliac vein. A non-absorbable suture is then passed around the artery and tied 3 centimeters from the bifurcation of the common iliac artery. This is to ensure that the posterior division of the internal iliac artery is not compromised during the process. A second free tie can be placed distal to the initial ligature to help avoid recanalization. In this case, the obliterated umbilical artery is spared due to anatomical variation in this vascular network. Step 5B, vessel ligation using a contemporary clipping technique. This represents a safe alternative to the suture ligation technique. Complete isolation of the vessel is not required during this technique. This helps to avoid the extensive dissection involved with suture ligation, potentially decreasing the risk of injury to adjacent vessels. This technique involves placement of 2 large vascular clips 3 centimeters distal to the bifurcation of the common iliac artery.
Excellent. We'll go to the next slide. So you can see the remainder of that video at cansagevideos.com where the rest of it will be. So the second half of this talk is about invasive placentation. So we'll go to the next slide. So this is a picture of something that you might find at a planned hysterectomy. This is also a picture of something that you might find incidentally, which has certainly happened to many of us. And myself and Dr. Sanders had the pleasure of joining an already established placenta invasive placentation team here in Calgary that's run by Dr. Birch and Dr. Jen Susi. So there's 5 of us now on this team, and we have a volume of roughly 1 or 2 of these high-risk cases a month. And so we work with our national collaborators, but I thought I'd go over some of the things that we do here. So next slide, please. So the prevalence of this is about 0.1 to 1%, and really that's felt to be due to defective decidualization in an area of scarring from previous surgery that changes the way that the placenta embeds. So that can be a placenta previa with previous cesarean sections, myomectomy, Ds and Cs, hysteroscopic procedures, and other ectopics. And you can see that there's a variety of different levels of invasion from accreta to increta to percreta, and a percreta essentially is through the serosa and into other adjacent organs. So next slide, please. So here in Calgary, we have a large program that works with MFM, OB anesthesia, gynecologic surgery, NICU, and psych, and essentially these cases come to us from, in general, ultrasound, where a diagnosis is made usually in the early 2nd trimester. And these patients are followed with MFM and gynecologic surgery team to optimize their care and plan for their delivery. We usually stratify them based on the ultrasound findings of low risk, intermediate risk, and high risk, and then manage them accordingly. And so MFM is useful also for perioperative planning and scanning of our patients before we take them to surgery. So If they do end up in the care of gynecologic surgery, some of these patients actually have cesarean scar pregnancies, and some of them also have second trimester terminations, and these are usually done under the care of our gynae service. We often will plan their deliveries for around, and depends on the nature of it, somewhere between 34 and 36 and 6 weeks. And we also involve other services. Sometimes we need interventional radiology, sometimes urology, sometimes vascular surgery, and sometimes general surgery. And we have we generally do these in the trauma rooms, which have advanced imaging available to us. We often have 30 or 40 people in these rooms. And I think Dr. Thompson really covered the OB anesthetic part of it quite well. But one of the things that I did want to highlight is that we involve our psychiatry and our psychology team quite early with women's mental health, because of the high risk of PTSD from the nature of some of these cases. Our highest risk AIP, or abnormally invasive placenta cases, are usually delivered in the 36th week. If there's other risk factors with antepartum bleeding or cramping, we will go earlier. And those who are lower intermediate, we do slightly later. Next slide, please. So there are a few things that can happen to these patients after they're identified. One of them is an early cesarean scar rupture, which actually this is a photograph of, is a cesarean scar pregnancy that started to rupture at around 18 weeks. So that's something that can happen. We also have patients that miscarry with invasive placenta that run into massive postpartum hemorrhage. One of the things that also happens is a vaginal delivery with massive PPH to follow. And then we have our surgeries. And so some of these patients, the vast minority, elect for planned cesarean section with conservative management, which I'll talk about. There are some who go for focal resection. Those are the low intermediate risk. And then there's our high risk of invasive placenta who go for a hysterectomy at the time of their cesarean section. So next slide. So in patients who are extremely motivated to keep their uterus with invasive placenta, we do talk a bit about expectant management, and conservative management is not something that we do frequently. It has been discussed, and there is good evidence for it abroad, but for the practicalities of it are quite challenging. Essentially, the placenta is left in situ after the baby's delivered. The hysterotomy is closed, and over time, the placental tissue necroses and detaches. This carries a pretty high risk of hemorrhage, sepsis, and recurrence of invasive placenta. We do recommend at least 10 days of antibiotics, but methotrexate is not really recommended. So the next level up is essentially our intermediate risk. So these are areas of focal accreta. Usually these patients have had previous surgery of some kind, myomectomies, DNCs, where in general, we don't think the placenta is as invasive, but there are areas that can potentially be invasive focally. And so what we often do here is either a midline or a phalansteal. We try and remove the placenta very delicately. If there's clearly no plane, we proceed with our hysterectomy. But if there is a plane, we might remove the placenta and employ some of our other methods to control the bleeding. So they usually Bacri, and then repair the uterus, and then continue to monitor them in an ICU or in a high risk set, in a highly monitored setting for the need for hysterectomy. Now, if we do need to move forward with a hysterectomy for our high risk patients, what we do is we activate our multidisciplinary team. This is a team that works together all the time with 2 or 3 staff surgeons activating who are active at the same time. And we plan for hysterectomy. And I'm going to take you through a little bit of what we do here. So next slide. So when we say center of excellence, and this is a paper out of Toronto who undoubtedly has the most experience with placenta accreta spectrum in the country, and they published 2018 FIGO guidelines on it. And essentially what a center of excellence means is universal access to this team with a standard care plan, with availability of neonatal ICU, with adult ICU, and massive transfusion capability, which is essentially what we have set up here at Foothills. Next slide, please. So the first part of this is perioperative setup and planning. So these patients are admitted to hospital usually a day or 2 before. They have additional blood work and imaging done. Then we bring them into our OR, prepare them in lithotomy. We have in general, neuroaxial anesthetic with our specialized invasive placenta anesthesia team. We have blood products readily available in the room, and we will often scan these patients for placenta localization. We also have the possibility of interventional radiology balloon placement if we want to use that, but we have started to use that less and less frequently. Next slide. So we insist usually on a midline laparotomy in this circumstance, and the reason is that it gives us superior retroperitoneal access, enhanced access to the pelvis, allows for easier dissection of the bladder, and allows for a fundal incision. Next slide, please. So what you see here is the fundal hysterotomy, and I actually call this in general a posterior classical, because what I usually do is start well above the uterus, as you can, well above the bladder. You can see the reflection of the bladder here. What we do is we make a classical incision at the fundus, and in general, we travel posteriorly because we know that these are usually anterior placentas, and we travel as far away from it as possible to deliver the baby through the fundus without disrupting the placental bed. So the first step is once the cord is clamped and cut, we put it back into the uterus. We close the hysterotomy with our #1 PDS in a running fashion. And this is usually when we administer TXA. In general, we do not give uterotonics before the placenta is out. So next slide, please. So this is where we move on. And this is a particularly difficult case. This is from one of our recent cases that had parametrial involvement, as you can see from the lateral placental invasion. It had anterior and bladder involvement, and this also had rectovaginal septum involvement. So this was one of the cases where we definitely used a internal iliac ligation. And in general, our stepwise way of doing this is we do the round ligaments, a retroperitoneal dissection, we take the uterovarian pedicles, then we do a ureterolysis, and potentially an iliac ligation if it's feasible. And we have started to use a ligature impact energy device at a lot of these cases to help facilitate the desiccation of some of these vascular pedicles. So essentially we devascularize the organ and then move forward with the bladder dissection, because usually most of this pathology is anterior. Next slide. So as mentioned, the last thing we do is the bladder flap. So we have a devascularized organ, and we take the bladder down meticulously with usually clips and monopolar, and then either do a subtotal or total hysterectomy, and then whatever needs to happen on the bladder. If the bladder has involvement directly, sometimes we have to do a planned cystotomy with repair. But in general, we take it slow and we try and avoid bladder injury. The salpingectomy is done last, and we often do an oophoropexy and follow these patients in our high acuity unit. Next slide. So the conclusions that I want you guys to take away from this are #1, the first line of therapy should be ideally compressive balloons, followed by compressive stitches by laparotomy. If that fails to work, then devascularization of the uterus via internal iliac ligation via by contemporary means. And if that's the other thing I want to mention is, if we need to, then invasive placentation is best done at centers of excellence with multidisciplinary rehearsed teams. But I do think that internal iliac ligation is an important step that should be taught. And if you want to see Dr. Sanders' video, go to cansagevideos.com. And so with that, we're going to move on to our next speaker, please.
Thanks, Michael. So I want to start by just introducing the topic of iron deficiency and iron deficiency anemia in pregnancy. So one of the pillars of patient blood management, which I will speak on shortly, is aggressively managing iron deficiency. And by doing so, we can reduce not only use of blood products, but the sequelae associated with blood transfusions and the illnesses itself. Next slide, please. So in in doing my work on iron deficiency and iron deficiency anemia, I've been a consultant for Pfizer. So in discussing the use of iron isomaltoside in OBGYN. And we'll disclose that the honorarium from this webinar is going to be donated to the OC Department of OBGYN. Next slide, please. I'd like to acknowledge that I'm presenting from the traditional, ancestral, and unceded territories of the Coast Salish people. I'd also like to thank Stephanie Cooper for the invitation to speak tonight, as well as for Sonia Kong and Faring for providing the space for us to gather physically distant. And I have to acknowledge the hard and tireless work of Dr. Christine Lett, who's been an inspiration for myself, but also has done a lot of the groundwork on treating iron deficiency and recognizing iron deficiency and anemia in pregnancy. Next slide, please. So I did send out initial objectives, but I have since modified them. Can we go to the next slide and I'll quickly touch on them. So first I want to review anemia and iron deficiency and the epidemiology in pregnancy. I want to review the iron requirements, highlight patient blood management as I introduced. We're going to review oral and IV iron use. I'm going to review the rationale for and the use of an iron algorithm for pregnant patients, and we'll finish off with some useful practical tips. Next slide, please. So anemia is defined differently in pregnancy than non-pregnant adults. The World Health Organization defines anemia as a hemoglobin of less than 110 at all points in pregnancy. This is also supported by the Network for the Advancement of Patient Blood Management, Hemostasis, and Thrombosis, which is colloquially known as NATA. FIGO also supports this. So the UK guidelines and ACOG and the CDC use different cutoffs. And again, none of these guidelines factor in altitude, which relevant for our populations above 1,000 meters, which roughly equates to about a 3 gram per liter decrease in hemoglobin. Next slide, please. So the normative values that the CDC uses comes from several small studies. The problem with these normative values that they come from only data sets of approximately 500 total. So one of the studies, the biggest one, was about 200 patients. And all of the studies that this normative data comes from supplemented patients with up to 200 milligrams of elemental iron. So typically we would not see this in pregnancy. Probably if iron was not supplemented, we'd seen a steady decline. But either way, the WHO and NATA advise 110 as a cutoff throughout pregnancy. Next slide, please. Now, iron deficiency is certainly not the only cause of anemia in pregnancy, as you'll see a variety of other causes. There's a whole differential. But the Pareto principle tells us that focusing on 20% of the problems will yield 80% of the results. Next, please. Yeah. So by far, iron deficiency is the highest prevalence, and I want to focus on that here today. Next slide, please. So first question is, what level of ferritin is suggestive of adequate iron stores in the first trimester? And this would, under the assumption that you don't need to supplement at any point in the pregnancy. How do we do? So by far the most popular response was 30, but the correct answer is 70. We'll go to the next and I'll chat a little bit about that. So there are significant iron requirements in pregnancy. The total requirements are approximately 1 gram, and that would be in a singleton pregnancy, which equates to approximately 4 milligrams per day. Now, this is not intake, this is actual utilization, so factoring in absorption. So without any supplementation in pregnancy, it would require a pregnant patient to have 500 milligrams of total body iron stores, and this equates to a ferritin of approximately 70 to 80. So in counseling patients, if you see a 70 to 80 ferritin, you can say that you probably won't become anemic in pregnancy. However, by the end of pregnancy, someone will definitely be iron deficient. So the recommended intake in pregnancy is 27 to 40 milligrams per day, and that's of elemental iron. And again, this is not factoring in absorption, which at best is approximately a third. Next slide, please. So similar to anemia, iron deficiency itself has various cutoffs. So it traditionally used to be less than 30, and the less than 30 corresponded to what level bone marrow could not be stained for hemosiderin. But as lab studies got more sensitives, lower cutoffs have been used. So these normative values have reduced the detectable level of ferritin. And so instead of using 30, more and more we're seeing numbers that are less than 12, less than 15, which just mean that ferritin is not really detected. Using a cutoff of 30 nanograms per milliliter is a 92% sensitive and 98% specific test. So it is by far the best test for iron deficiency. If you suspect that a patient is iron deficient with a ferritin of greater than 30, your next best test is your transferrin saturation. So with these differing numbers, we can see that this would have an impact on literature as well as protocol. So from this point forward, we would use 30 as the cutoff for normal, and again, 70 would be consistent with no need for supplementation. Next slide, please. Okay, so another question, how many ounces of beef per day would one need to eat to equate to the recommended amount of iron intake per day? I.e., if you didn't have any other intake of iron per day, how much beef would you need to get the recommended daily intake? 8 to 10. So the correct answer is 28 to 40 ounces per day, which is absurd. Next slide, please. And it just goes to show you how challenging it can be to maintain iron stores or even become less iron deficient in pregnancy. Next slide, please. So this is from a resource from BC here that demonstrates how much iron is in any given nutritional food. So beef, you can see per 2.5 ounces, you have 2.4 milligrams. So you can say if you're trying to get 27 to 40 milligrams per day, you would need to eat essentially 27 to 40 ounces of beef per day. Next slide, please. So this is probably one of my favorite diagrams that I've encountered in doing this research, but it really reiterates the need to screen women and pregnant patients for iron deficiency. If we typically just do a CBC, we wouldn't see reductions in values on a CBC until a patient is in stage 3 iron deficiency. So on the very bottom corner, you can see that the MCV and hemoglobin only start to drop once you have not only no storage iron or transport iron, but no functional iron. And that's going to be one that's a lot harder to come back from. When your ferritin starts dropping, you're in stage 1 iron deficiency, and it's much easier to correct that and not become anemic in pregnancy. Next slide, please. So from looking at Canadian data, there's actually not a whole lot of literature that demonstrates the rates of iron deficiency and anemia. The earliest data comes from the Nutritional Canadian Survey, which found that anywhere from 3 to 66% had a ferritin of less than 12 micrograms per liter. Which is fairly significant. Probably the best data set, or I guess I would say the most robust data set, has been the APRIN cohort, which, however, was self-referred to study maternal nutrient status on outcomes. And from that study, was found 5% rate of iron deficient anemia in 40% of patients who were iron deficient. And a significant amount of these patients were taking iron in pregnancy. And again, with self-selected, you can imagine that this is not representative of the general public. Next slide, please. So this data was shared generously from Dr. Christine Lett in Saskatchewan. So she and her group looked at the rates of iron deficiency and anemia in their patient population. And basically they screened their patients with a ferritin at the time of their glucose tolerance test or the gestational diabetes screen, and found an iron deficiency rate of 79% and an anemia rate of 8%. And postpartum, there was almost 1 in 2 were anemic. Next slide, please. So there are some well-established associations with iron deficiency and iron deficiency anemia, some of which are due to low intake, poor absorption, losses, and systemic deficiencies. Next slide, please. There are a significant number of comorbidities of not only iron deficiency anemia, but also iron deficiency, and they pertain to the pregnant patient, the fetus, the neonate, childhood, and then the health system as a whole. I won't spend too much time on these because I want to get to the practical points. I'm happy to chat about this later. Next slide, please. So Dr. Thompson already touched base on it, but essentially transfusion, there are significant risks associated with it, including a 1 in 200,000 risk of death from transfusion alone. There are other risks, including minor reactions, alloimmunization, which ranges anywhere from 1 to about 11%, as well as the burden of disease or just not seeing the desired response from a transfusion. Next slide, please. As we know from choosing wisely that we shouldn't be giving blood based on an arbitrary number, we shouldn't be giving blood if another treatment would work, and we should only be giving 1 unit at a time. Next slide, please. So the 3 pillars of patient blood management are comprehensive anemia management, minimizing iatrogenic or intraoperative losses, as well as optimizing patient tolerance of anemia. For the purposes of today, I'm just going to be focusing on the comprehensive anemia management. Next slide, please. Here is some literature that just shows the value in patient blood management. So this is from a health system in Zurich, which implemented at least one of the 3 pillars. And from that alone, there was a 27% reduction in transfusion. And for the healthcare system, that saved about $84 per patient, which equated to a $2 million saved. The meta-analysis looking at all of these studies, including over 200,000 surgical patients, found that when a 3-pillared patient blood management program was used, there was almost 60% fewer transfusions per patient and significant reduction in complications, hospital stay, and more than 10% reduction in mortality. Next slide, please. So one of the formulations that is, let's say the formulation that is most commonly used in our pregnant population is iron sucrose. It is an iron hydroxide core with particles in a colloid suspension. So when administered into the blood, these will rapidly dissociate, and this is responsible for the reaction, which I'll touch on the next slide. There's no evidence of teratology in pregnancy, and there's a lack of safety data in the first trimester. So typically IV iron is not administered in the first trimester. A lot of the hesitation with IV iron relates to historical use of IV iron dextran, but this is no longer available. As far as AHS is concerned, when I was last there, Venofer was the only formulation of IV iron available. Soon to come, if not already accessible within the health system, is going to be iron isomaltoside, which I mentioned from Pfizer. But basically, we'll be able to give a higher dose of IV iron in a single treatment instead of breaking up a treatment over multiple days or even weeks. The Venofer itself was approved for up to 500 milligrams at a time, but most literature uses 200 milligrams. So generally 200, 300 milligrams are used at a time at frequencies generally no more often than every 2 days. If a patient is admitted in hospital and you're trying to up their iron levels, a good indicator is their TSAT after 48 hours, as opposed to assessing a ferritin, which is going to be quite high because of the rapid dissolution of the compound. Next slide, please. Sorry, can you go back one slide? There we go. So just a few things I want to touch on here. So the Fishbane reaction is what is what people normally think is either an anaphylactic response or hypotensive response, and that relates to the dissolution of the hyperosmolar suspension. And this reaction can be mitigated by slowing an infusion down. Generally, a reaction will not happen with a second infusion, and it can be pre-treated with an antihistamine or a steroid, but generally is not necessary. Anaphylaxis has been reported on the monograph as frequent as 1 in 44,000, but most of the meta-analyses on safety tend to equate it actually with the risk of death in a blood transfusion, so about 1 in 200,000. Next slide, please. So this study I just wanted to throw in to demonstrate the use and utility of basically an optimally dosed IV iron patient compared to red cells. So this group did a pilot study looking at giving the maximum dose of iron isomulticide, so 1,500 milligrams, which would be generally about 5 treatments of Venofer compared to red cells. So if you can go to the next slide, please, we'll see a diagram of what happens. So on the left side, we see what happens to hemoglobin in the first 7 days. On the right-hand side, we get days 7 to 84. So initially with PAC cells, we get on day 1 a significant elevation of hemoglobin, but by day 21 to 84, you have a significant difference in hemoglobin, which obviously you're going to anticipate. We don't have data yet to say that we're going to anticipate improved functional status, but we can't say that yet. On the second row, you see reticulocyte count is significantly increased with IV iron as opposed to red cells. And actually the hemoglobin content in reticulocytes is depressed when you transfuse someone with red cells versus when you infuse them with iron. So by day 3, you can already see a significant difference in the amount of hemoglobin in a reticulocyte with the iron isomulticide. Next slide, please. So iron supplementation, generally first line is oral unless they have contraindications, which we can chat about a little bit later. The best absorption is about 1 in 3 or about 30%, and that is taken on an empty stomach with vitamin C or another acid. It should be not taken with food or calcium, which reduces the absorption by about 50%. I will get to a slide in a moment that shows evidence for improvement of hemoglobin over a time frame, but generally you should see at least a 10 gram per liter rise in hemoglobin if someone is anemic. From a Cochrane review, we do see a reduction in maternal anemia, iron deficiency, and term iron deficiency when you supplement with iron. There is a trend towards a decreased preterm birth and low birth weight, but this was not statistically significant. Historically, iron has been dosed daily and multiple times a day. Kind of the rationale was that we need to be able to get it in as much as possible if they're going to absorb only a fraction of it. However, one of the key regulators in iron absorption is a signaler or a protein called hepcidin. If you can go to the next slide, we'll have a diagram of the role of hepcidin. So when you have significant inflammation, i.e. Major surgery, infection, or if there's an iron load, the liver will produce hepcidin, and the more hepcidin that's circulating produces an inhibitory reaction on not only the absorption of iron in the small intestine, but also the binding of transferrin in iron, as well as the storage of iron in the liver. And next slide, please. So Moretti et al. were probably the first group to really look at the different effect of making iron dosing every other day. Actually saw that after 48 hours, there was a reduction, an optimal reduction in hepcidin, and that actually didn't improve with longer dosing, a bigger interval of dosing. This group looked at daily versus every other day iron dosing, and they also looked at daily versus BID dosing. And this study was powered to detect a 30% difference. And there was a significant difference after the equivalent of 30 doses. So what would be 60 days for a every other day dosing or 30 days for an everyday dosing, which related to a 7 gram difference in hemoglobin over the study period, which was significant. And not only did it improve hemoglobin, but it also reduced the side effect profile, which we can infer that it probably enhanced compliance. Next slide, please. So this group set out to assess the improvement over a time frame, for predicting hemoglobin rise. And now this was done prior to, I would say, the more ubiquitous knowledge that hepcidin impairs iron absorption. So these were using BID and TID dosing, which we can assume resulted in less compliance and more side effect and perhaps even less and probably less absorption. But of those who responded, there was within 2 weeks, there was a 10 gram per liter rise in hemoglobin. And of those who did not meet the 10 gram per liter rise in 2 weeks, the majority didn't actually reach greater than 10 overall in 8 weeks. So if someone's going to respond, we should have been able to detect it within 2 weeks. Next slide, please. And that's what this little diagram shows, is that we should be able to predict someone's response even within 2 weeks. But I will bear in mind that when we're giving iron every other day, we're probably getting less in. So even being conservative and saying reassessing after 4 weeks, we should see at least a 4 gram per liter rise. Next slide, please. So next question is, which is your go-to iron formulation in pregnancy? Do you use an iron salt, so one of the ferric salts? Do you use an iron polysaccharide such as Ferromax, heme iron, so Proferrin or Optifer Alpha, or the classic 2 pounds of beef per day? Nice. Okay, so still a significant amount of people are using iron polysaccharide. But we're seeing, I think that ferric salts are going up as this information is getting distributed more and more, which is awesome. Next slide, please. So here what we can see is these are basically what was on the previous slide. I think a little bit from the bottom got cut off. I'm not sure if you can see at the very bottom is the polysaccharide iron complex, but this basically shows the difference in cost. And what I wanted to highlight was the cost of Ferromax per month. If you're seeing it like I'm seeing it, it's cut off, but the cost of Ferromax per month is about $20 to $26 per month versus your ferric salts, which is about $6. Next slide, please. So mostly for the Ferromax lovers, how long does it take for hemoglobin to increase by 30 points with Ferromax? Weeks. I mean, that would be nice. The answer is 60. We'll go to the next slide. So it takes an absurd amount of time, almost 2 pregnancies worth, to increase the hemoglobin. Next slide, please. This is a great slide. This is from Dr. Christine Lett, so I'm going to give her all the credit for this one. That has the time interval for what it takes to correct hemoglobin. So you can see that, if you're trying to achieve the same goal for Ferromax, it's going to take about 5 times as long as your iron salts. And again, the cost comparison. So by far cheapest, most effective, ferrous fumarate or one of the other iron salts. Next slide, please. This was one of the first obstetrical QI projects that was done, looking at the role of patient blood management in obstetrics. Next slide, please. And this was like a 25, so of the 3,000 deliveries, they took the first 25 and were trying to figure out why people weren't having, or why people were getting to pregnancy or term pregnancy and not having had their anemia addressed. By far the most common reason, maybe not by far, but the most common reason was the lack of a standardized testing for iron deficiency, but also not having a protocol, no pathway for IV iron. So things that could be easily instituted to make a difference. Next slide, please. Next. So those were the information handouts that were given. This is the amount of testing for ferritin. Next. As you can see, as this was implemented, more ferritin tests were gone out. On the left, you see the total number of transfusions declined over the 2-year span. And on the right side, the number of single unit transfusion increased over time. Next slide, please. So instituting this protocol, we saw a reduction in transfusions, an increase in single unit transfusions, no reduction in transfusions less than 70, and a cost saving of almost 4,000 per month in blood products alone. Next slide, please. So this is from a group in Toronto that looked at basically applying the same thing to a patient population locally. Next slide. I wanted to bring up one of the points that they focused on was the cost of ferritin. So what does it cost, total lab cost, to assess a ferritin? Okay, next slide for the correct answer. So super cheap, not something that should really be a deterrent. Next slide. So you can see in implementing this project, you can see that there was just in the lab cost alone a $1,700 fee or doing all of the ferritin tests, which equates to 2 units of transfusions if you calculate nursing and nursing and supply cost, or 4 transfusions if you only count blood products. So for sure, it's definitely cost savings. This group saw 21% reductions of hemoglobin less than 100 at term and 30% reduction in transfusions. Next slide, please. This is the algorithm that Alberta Health Services has been using, and it's been based on, again, Christine Lett's work. There's a few things that I want to point out. So the orange category versus the red categories. The orange category is when someone is not anemic, but they are iron deficient. You can use a lower amount of elemental iron to achieve a better compliance, lower side effect profile, not treat as aggressively. Whereas when someone's anemic and iron deficient, or I should say when someone's iron deficient and anemic, you want to be a little bit more aggressive with iron. And if they are significantly or severely anemic, less than 80 to 90, you want to jump right to IV iron, or if they have any other contraindications to oral iron. Next slide, please. A few things to point out here. As I mentioned earlier, we should see a 10 to 20 gram per liter rise of hemoglobin over a 4-week span. So if you're initiating iron, plan to reassess it in a month. Postpartum, I would say this one is a little bit more open to interpretation as far as when you use IV iron, but we should definitely be treating moms with anemia after delivery if their hemoglobin is less than 110. On the left, you'll see other causes for anemia and iron deficiency. And again, if you're wondering about assessing someone's level of iron deficiency, probably looking at their transferrin saturation is going to be more useful than an acute phase reactant, that is the ferritin. Next slide. So last one here is some iron supplementation tips. So what I have found with to help with compliance is really counseling on the importance of adequate iron levels. So invoking the rationale for neurodevelopment for anemia in childhood. That definitely a lot of people find that if they understand the reasons why, I find that they're much more motivated. So start low. So in general, and I know Christine Lett's teaching is basically use ferrous fumarate. Either don't waste your time trying to figure out how much elemental iron is in ferrous sulfate versus ferrous gluconate. Ferrous fumarate, if you give 1 tab of 300 milligrams, you're going to get 100 milligrams of elemental iron. So that would be a good dose for someone who's iron deficient and not anemic. Or if you want to get buy-in, start with just a single tab. And if someone is anemic, you would do 2 tabs of ferrous fumarate, which equals 200 milligrams of elemental iron. Best done on an empty stomach with vitamin C. I find for my patients who don't eat before bed, just do it right before bed, and they seem to find that there's no significant side effect profile. We should be assessing response in 2 to 4 weeks. I think 4 is probably plenty unless you're in the 3rd trimester or if it's severe. And at follow-up, you always want to assess compliance. So just make a little note in your prenatal, say, how's it going? Do you need a refill? That can often be an easy barrier to overcome. So giving sufficient refills, both in the antepartum as well as in the postpartum period. And that is it for me.
So I think we're all going to put back on our videos and unmute ourselves, and Ariela is going to go through some of the questions.
There was one more question for everyone to answer regarding Dr. Papalia's presentation. Thank you everyone for adding such thoughtful questions in the Q&A throughout. What I've done is just collect them and I'll kind of dole them out to some of our presenters. And if anybody has specific thoughts on the questions, feel free to jump in. We'll start from the top and work our way through the talk. So Dr. Cooper, you mentioned you provided some statistics regarding PPH and mortality associated with it on a global level. Someone was wondering whether there is a known correlation between maternal death from PPH and the care provider providing care in that delivery and or a resource setting. For example, in lower resource settings, is there a higher risk of maternal mortality in PPH?
Yeah, there's, oh, sorry, go ahead.
No, let Rob go first.
There's a clear correlation in countries that have low resource settings. So in areas where you don't have trained adequate personnel for birth attendants, and also where you don't have drugs for active management of the third stage of labor, in those settings, there will certainly be a higher risk of maternal death with postpartum hemorrhage, and that's pretty clear.
You know, maternal death, I was going to say the same thing. Internationally and in low resource countries, we have for sure seen that. In higher resource countries, including Canada, we don't always have a system so that we can actually analyze the systemic factors that led to a maternal death. So there is no system in Canada where nationally we actually look at deaths and say, okay, these are the, you know, potential causative factors. We do it in Alberta, but even then, the number of cases over 10 years of a hemorrhagic death are obviously very low. So I think, you know, certainly the US with, you know, the collaboration that I mentioned in the UK, they are finding, you know, factors, but I don't think we have enough cases to specifically say, or take lessons to say it's related to a specific setting. To say that it's so, you know, a tertiary setting is less likely to happen than a, a rural hospital.
That's great. Anybody else have anything to contribute on that topic? If not, the next question I think is really interesting and relevant because I think timing of the second stage is a hot topic with that recent meta-analysis that came out that's getting quite a bit of buzz around passive second stage. So someone asked very astutely if there was any associated, like tangible association between length of labor, specifically the second stage, and risk of PPH, I'm assuming secondary to atony.
So obviously the studies, there's a mixed bag, a lot of small studies, medium-sized studies, retrospective, all observational, but there appears to be a correlation with the length of the second stage for sure, and in some cases the first stage, but there's not always a clear definition to say, you know, what risk is with what time period in a good study. However, some studies have suggested that the risk is related to the pushing part, so that the passive stage is not increasing the risk. So if you wait for the baby to descend, if a mom has an epidural, for example, that if you wait 2 hours or 3 hours, for example, and then she only pushes for an hour, it's not, you count the time pushing. But I think there is the data is not 100% yet, but obviously, Ariela, I don't know if you have thoughts on that as well.
No, I think I agree with you. There was a lot of, when you read that specific, I'm just thinking of that specific meta-analysis that came out, there was quite a bit of heterogeneity in the studies as well. And PPH was not a primary outcome, but certainly agree based on what I've come across in the literature.
One of the big things that as I've looked at PPH studies, it goes back to the fact that how bad we are at actually recognizing postpartum hemorrhage and our definitions of postpartum hemorrhage. So, you know, we say a vaginal delivery less than 500 mil, or sorry, greater than 500 mils is a postpartum hemorrhage. But when we did our assessment of 4,000 deliveries at the foothills, our average blood loss for a vaginal delivery was 580 mils. So if we are not actually measuring blood loss correctly, how can we actually make any accurate summaries or accurate conclusions about the effects of postpartum hemorrhage if we're not even doing that correctly? So if we start actually having objective measurements of blood loss, then we may be able to have more answers to these questions.
I think that's a very important point for sure. Speaking of accurately measuring blood loss, good segue into the next question that a couple of people had asked. So, Dr. Cooper, you mentioned very briefly in your talk about, and I think Dr. Thompson alluded to this as well, that we may be seeing an increased risk of bleeding, particularly at the time of C-section, now that we're doing fairly universal delayed cord clamping. Wondering if there's any evidence to support that. And someone also brought up an anecdotal evidence of increased bleeding at the time of cord blood sampling collection. And if there's any evidence to support that as well, I think as we counsel patients on the risks and benefits of cord blood collection.
From everything I've read, there does not seem to be an increased risk of postpartum hemorrhage with delayed cord clamping. When you take blood for cord stem cells, it's from the fetal placental circulation and not maternal. So that's baby's blood and not mom blood. So, but I think the question is if you're delaying taking the placenta out, are you increasing? But I think as we've looked and Rob alluded to that too, with active management of the third stage of labor, it's the need for the uterotonics like oxytocin or geritocin that has been shown to reduce the risk of hemorrhage, not cord traction. So my thought would be no, we're not at an increased risk of postpartum hemorrhage. And with C-section, you know, clinically, and I don't have data to support this, but I have not seen an increased risk, and we do delayed cord clamping and have been doing it probably about 3 years now routinely for all C-sections. I haven't seen it, but if there was that concern, then yeah, you clamp the cord and baby goes off to the warmer.
Perfect. And I think that brings us to a nice segue to a few questions on active management of the third stage. And Dr. Thompson, you were primarily discussing this in your talk, but if anybody wants to contribute to this conversation, of course, welcome. Someone asked if there are any Canadian studies of combined ergonovine and oxytocin, which is sinometrine, which used in the UK. And I think someone answered in the chat that it's not routinely available in Canada. And I don't know if anybody else has any other data or information to contribute around that. Sounds like that's the case. Not available in Canada.
That is not available. Rob is nodding.
Yeah. Another question regarding.
There was no benefit from what I saw, which surprised me because I thought there would be, because ergot is such a, ergotamine or ergot is such a great medication when you have a hemorrhage. But I was surprised with the studies that I read again. And somebody can correct me if they know the studies better, but I did not recall there being any.
What I think the issue was is that it was associated with increased tissue retention. So I think that offset any additional benefit. And so it was likely giving the ergot too early, and then you'd end up with retained products. So there didn't seem to be, and at least that's what was brought up in the discussion of some of the papers.
Interesting. That's really, I think, important to be mindful of for sure. Another question on active management of the third stage. So I think this was a question, I guess, for anyone in the group about what their specific site or our specific site is doing in terms of oxytocin administration, or what drug is administered for active management of the third stage, both in cesarean section and in vaginal delivery.
Currently, SOGC guidelines, and I would agree, recommends oxytocin for routine vaginal delivery. We did talk about geritocin, and it is a good drug, but it is significantly more expensive for routine vaginal deliveries. But SOGC guidelines do suggest for high-risk deliveries, potentially you can consider that. And I think Rob also brought up a really good point about considering prophylactic TXA as well for high-risk deliveries. And we do geritocin for all cesarean sections. And I know Rob has some good insight on that maybe he can add. And I'm sorry, before I get to that, I saw in the questions as well about the dose and the route. So with oxytocin, there's a theoretical risk of cardiovascular complications with fast IV. So we either give it as a slow push over 1 minute for an IV of 5 milligrams. Or IM 10 milligrams.
Yeah, and really there's no benefit in giving it IV versus IM, so it is somewhat safer. It's obviously painful to get it IM if you're giving it in an area that's not frozen. I think the benefits of carbetocin would be patients that are at higher risk, and there is some evidence that it's probably better in a higher risk vaginal delivery, and the SOGZ guidelines would support that. And then for cesarean section, we tend to use exclusively carbetocin for a couple of reasons. One, evidence would suggest that it may be more beneficial. And secondly, you don't need a prolonged infusion of oxytocin afterwards. You just need the single dose. And so the cost isn't significantly different when you take into account all the oxytocin that you'd need to draw up and give to run the infusion later. So the cost isn't a major difference. And there is some evidence that there's less uterotonics needed for rescue using duratocin versus oxytocin. It's not super robust, but there is a trend towards needing less uterotonics with it.
Great. There's one more active management of the third stage question. And someone asked whether there were any studies or any evidence to support the use of TXA prophylactically as in active management of the third stage.
The only ones I've seen have been for treating using it prophylactically in high-risk patients, and in those there has been some evidence to suggest that it is helpful and there will be less bleeding. But as far as all comers, I haven't seen any studies that have looked at that.
Yeah, I agree. I mean, certainly, we give it to moms with von Willebrand's or has had, a very significant history of repeat postpartum hemorrhage and prior deliveries, but not routinely, and not that I'm aware of, as Rob said, of any data to support that.
And I mean, it works pretty quickly as well. So I think it seems to be not harmful and it doesn't seem to increase venous thromboembolism, but that may change if we started using it for absolutely everyone. So I think with the current evidence, I don't think it would support giving it prophylactically to everyone. But as I said, it does, I think, benefit patients that are at higher risk or people once they are bleeding using it very quickly.
I'll ask a question back to Rob because one of the issues that we had when we were doing our algorithms to use TXA was about the fact that you had to have a separate IV, and because there's potentially incompatibility with oxytocin. And your thoughts on that? I mean, what we decided as part of our algorithms is basically if you're needing, beyond oxytocin and ergotamine, you should be getting a second IV line anyway. And also because outside of like a physician administration, TXA, the product monogram says that you have to infuse it over 10 minutes. That 10 minutes of waiting for TXA to go in when you should not be delaying use of the appropriate urotonic in that time period. So, but I guess what your thought about infusion rates and IV access for TXA?
So, I mean, yeah, according to the product monograph, you should have a separate IV. In practice, we don't, especially in the non-obstetric population. We certainly never start a separate one to run it. And we use it quite frequently in the orthopedic population, some of the general surgery population, et cetera. And we don't run into any issues running it with other medications because it's given over a short period of time. As well, the 10 minutes, it's just not supposed to be given very quickly. And that comes from the cardiac literature where they were using 30 milligrams per kilogram IV push, and they got seizures in some patients. So in the patient population and the dose we're using, a slow IV push would probably not cause an issue. And in our case, that's what we often do, is a slow IV push over a minute or two. And we have not seen any issues with that at the doses that we're giving.
There was another medication question that was asked by several participants and a comment that's up currently in the Q&A regarding breastfeeding and hemobates and ergot. Dr. Thompson, I know that you answered in the Q&A that that specific recommendation is from the product monograph of both of those medications. And I know that ergot specifically has been documented to be found in breast breast milk, and that there is a small risk of nausea and I think vomiting in the infants, but someone commented in the chat currently regarding the importance of a discussion around risks and benefits and potentially being mindful to not discourage breastfeeding. However,
yeah, I think the risks are pretty low of any complications with that, and it's probably highly overstated to be careful of litigation in the product monograph. So I don't think there would be any issue with breastfeeding far earlier than that. There's just no studies on hemabate with transfer to breast milk, so they don't know, and it was shown in some animal studies to cause harm to fetuses. And then with ergot, there was some association with those side effects. But again, I don't think there would be any issue with breastfeeding. It's purely off what the product monograph says. And I do agree it is important to encourage breastfeeding and not discourage it. So I think you do have to weigh the risks and benefits. We just don't know what those are.
You know, clinically, we have not told women not to breastfeed. And I think there's more, I guess, more support about other, medications that women are given and diagnostic procedures. This whole like pump and dump idea is a bit overstated.
Yeah, I think certainly having trained in Calgary and the practice here now in Vancouver is, encouraging women to breastfeed following administration of these medications with a PPH, acknowledging the potential challenges with breastfeeding in general after a PPH as well, and trying to overcome those. I think there were a few more questions on medications. I'm just looping back to my list. Dr. Sanders is sticking around. I think I just saw a note that Dr. Secter might have to leave, but there are a few questions regarding surgical technique. And I think that Dr. Sanders answered this question in the chat, but in case anybody else wanted the specific answer, because I thought it was interesting for sure, the use of the specific utility of a Breisky retractor in the vagina to help with colpotomy at the time of a cesarean hysterectomy. How do you place it? What's it for? Tell us about it, Dr. Sanders.
Okay. So I'm here also.
Dr. Secter, sorry.
I am here. I'm about to go get handover, but the use of it is for really anterior fornix delineation. So, it's really helpful. I mean, it's hard to actually figure out where your cervix is in some of these cases because either patients are dilated or they have their cervix completely consumed by placenta. But if you do these cases in lithotomy and you use the Breisky retractor, sort of have the handle like this and the actual flat part of the retractor there, you can place it in the anterior fornix of the vagina and it can help delineate where you're actually going to make your colpotomy. So you can use it to figure out, number one, have you taken your bladder down far enough? And number two, have you taken your cardinal bites down low enough to actually complete a total hysterectomy as opposed to a subtotal?
Brilliant. Anything to add, Dr. Sanders, to that point?
Not really. I mean, you can also use it to delineate the posterior colpotomy. Sometimes it's a little bit more challenging posteriorly. The other thing that you can sometimes do is also use the Breisky to delineate your posterior and anterior colpotomy sites and then perform those just before you ligate your uterines so that you can get a nice big suture around your uterine pedicles.
Great. So a couple of options with that. That was helpful. Someone asked in the chat, and I think Dr. Sanders answered this as well, but the routine use of salpingectomy or routinely performing salpingectomy at the time of cesarean hysterectomy. I think that's the experience of the AIP group in Calgary, certainly. And I had a question about whether or not oophoropexy was done routinely by the group. Kind of on that same vein, the ovarian vein.
So yes, yes, salpingectomy is done, but it's certainly not done at the expense of the hysterectomy. So when the bleeding has stopped, the patient is stable, and we're finishing up in the pelvis, that's when we perform removal of the fallopian tubes. I wouldn't say that it's routine that we do oophoropexy. but it's certainly very common. I mean, the pedicle, when you take out the uterus, sometimes the pedicle is 20 centimeters. So you have an ovary that's basically dangling from an infundibulal pelvic ligament that's potentially very long. I mean, the incidence of post-operative torsion of an ovary like that is extremely rare. But nevertheless, sometimes what we do is we just reapproximate some of the peritoneum and just sort of reconstitute its original anatomic location, or pexy it to the distal stump of or proximal stump of a round ligament, rather.
Great. I know that there were lots of great tips around positioning, and I know that the routine use of lithotomy is pretty standard for the group in Calgary, certainly for both Dr. Secter and Dr. Sanders. Someone asked in the chat just now, any tips without the Breisky, I'm assuming for anterior and posterior colpotomy, for a case where someone won't be in lithotomy. It sounds like for the reason is for placing catheters. I also know that for balloon catheters, I also know that I've also seen it done in lithotomy as well, like low lithotomy, where you still have access between the legs, but there's no flexion at the hips. So if either Dr. Sanders or Dr. Secter want to talk about other options other than the Breisky and how you can maybe adapt positioning with a low lithotomy to also obtain balloon catheters.
So when you mean balloon catheters, you mean interventional radiology, I assume.
It sounds like that's the case in the question.
Right. So, another way of doing it is just with a simple sponge stick with a ring forceps with a sponge on it. That's one way of delineating the fornix. We're using less and less interventional radiology. I mean, it can be great. And I mean, there's certain cases where we have retroperitoneal involvement that would make doing an internal iliac ligation a total nightmare. And in some of those circumstances, we've had vascular surgery on hand, and they dissect out the common iliacs and the aorta with us. It is definitely harder to do balloon catheters when you're in lithotomy. And if we really think we need them, we will place the balloon catheters while the patient is supine before we initiate our case, and then place them in low lithotomy after. But it definitely adds quite a lot of complication to the actual placement of these. And it adds a lot of time and stress to a lot of these cases. So I would say that really we're using them a lot less frequently these days. Anything to add, Ari?
No, I don't have anything to add myself. I would just sort of echo what you were saying. Both here and then also during my training in Toronto, we were using balloon catheters less and less over time. There's sort of conflicting evidence as to whether or not there is any true benefit to them in the first place, and there is significant risk of complication, cost, and time. So we've moved to essentially doing most cases without balloon catheters, which therefore helps facilitate doing pretty much all of our cases in lithotomy.
I'd agree with that. I haven't seen, we've started using less and less, and there hasn't really been an increase in bleeding without using them.
Thanks, guys. There are a couple of similar questions. I think everyone really appreciates the importance of an AIP team and the role of a center of excellence in management of these complex cases with high risk of morbidity. But a couple of people asked if we are working in a center where we don't have access to a team like an AIP team, any specific tips on how to manage a case of an unexpected undiagnosed AIP, and what to do kind of as a part B to that question if you have an unexpected AIP and the placenta is half out, and any tips for management there.
So the very first time I saw Procreta, I was in a peripheral site, and it was a repeat elective section for a previa. And we took a look and we did the laparotomy, and we saw the vessels that I showed in one of my first slides. And we took one look at it, and we sewed the fascia back up, and we sent that patient to a center of excellence for the actual surgery. And there was no urgency. I mean, we were in a lucky situation where this was a planned elective C-section, right? I would think that if you're in an emergency and you have an undiagnosed or a newly diagnosed procreta during your surgery, I think that you need to, the biggest tips I can offer are call for help as quickly as possible, activate a massive transfusion protocol as quickly as possible, and involve probably a surgeon from another specialty. So general surgery can be helpful, gynae oncology can be helpful, trauma surgery can be helpful, urology can be helpful. People that have comfort in the pelvis in an emergency, people who can do internal iliac ligations, who can do retroperitoneal dissections, who can get you out of trouble. I mean, there are a lot of crossovers with a lot of pelvic surgeons, and I think that the sooner we get more help into an OR like that, the better off these cases go.
Yeah, and I would just add other sort of simple tips. I mean, if you have at least a few minutes, you know, make sure you optimize your exposure. So if you have a phantom steel incision, you know, you can easily convert that to a Cherney or a Maillard incision, which will give you more exposure. I mean, don't be afraid to tee your incision if need be, because ultimately exposure is going to be sort of your biggest friend if you get into significant bleeding. And take the time to sort of set everything up, have every team member that you need there, have blood there before you proceed, if you have time to do so. And just make sure you have good communication amongst all team members in the room.
To add to that too, I see a question here from Dr. John Kingdom about the use of a Reboa. So we recently had a case where we were thinking about using it, and we do have several trauma surgeons here who are actually trained to use it, and we were looking at actually getting some training within our department to do it. But the complication around it here is that they oftentimes can only use it for a short amount of time, and there's talk about heparinization and anticoagulation during the time of use, which would make it you know, quite tricky in these circumstances. I think there is going to be a role for it. Right now, we're not using it. We do want to get training for it in the right circumstances, but in lieu of that, in lieu of the Reboa for that particular case, we just had a vascular surgeon scrubbed with us.
We have about 7 minutes left, and there are a few questions that are specific to iron supplementation, iron deficiency anemia. So thank you so much, Dr. Secter. So I'm going to move ahead to some of those. Wondering if there are specific iron salts that are best tolerated with the fewest side effects and most effective, in your opinion, Dr. Papalia.
Yeah, I would say that there, you know, reviewing the literature, there's nothing that specifies one over the other. Purely from a practical point of view, the fumarate is the one that I go to because you get the highest amount of elemental iron, and it's the easiest to calculate because instead of having 35 or 60 milligrams of elemental iron, it has 100. So I use that just for purely to get the most bang for my buck. And so patients aren't taking 3, 4, 5 tablets a day, which seems daunting. So not really any literature to support that. And all of the literature that compares any of the irons treats them all the iron salts as a group.
Kind of on that same vein, if we're talking about the role of calculating how much someone's getting based on elemental iron, can you comment on why it may take so much longer to bring up someone's iron stores or hemoglobin with Ferromax, which is an elemental iron, versus iron salt? So Ferromax is a polysaccharide with higher elemental iron versus iron salts.
Yeah, so it's a bit deceiving. It is elemental iron. However, the way that it's bound in the molecule makes it not very well available, not very well bioavailable. So similar to how, for example, patients with irritable bowel syndrome can't break down a lot of polysaccharides or disaccharides, it just doesn't get processed. So it acts as a bit of an osmotic diuretic. So often people won't get constipated. That's why they love it. However, they're not getting constipated because that iron is not available to the gut to absorb. So you're basically just putting it through your gut. And I would put with the disclaimer that for some people it does work if they can break down that molecule, but it's not as predictable as the iron salts are.
That makes sense for sure. So that's helpful. There's a couple of other questions that are iron supplementation related. One in the chat right now that I think is really interesting. So often seeing a reluctance by clinicians to treat iron deficiency at 24 to 28 weeks because of a presumptive association of hemodilution in the pregnancy and not wanting to overtreat people's true iron levels. Can you comment on the role of hemodilution and iron supplementation in the second trimester if levels are significantly lower?
Yeah, so I would say, so we do know that hemodilution happens because the plasma volume increases disproportionately higher than the red cell mass. But I would also argue that as ferritin is a marker of both transport and storage iron, that you are consuming your transport and storage iron to facilitate that red cell mass. So although a reduction in hematocrit is normal and expected in pregnancy, and yes, a high hematocrit is associated with growth restrictions, IUFD, but generally it's when hemoglobin is on the higher end of normal, and that's what some of the literature from, there is a Cochrane review that looked at iron supplementation and levels of hemoglobin. But I guess my counterpoint to that dilution is saying, well, if our ferritin level is dropping, that would be an indicator that we are consuming more than is available.
There were also a couple of questions regarding the clinical evidence to support iron supplementation in pregnancy, as well as the clinical evidence to support a hemoglobin greater than 95, stating that there were a couple of studies that showed potentially not a significant benefit to it. However, you mentioned the role of iron supplementation in terms of neurodevelopmental outcomes, and someone else in the chat just now wanted to ask about the role of iron supplementation and breast milk production. So iron supplementation and clinical outcomes.
Yeah, so I would say so clinical outcomes are, we're going to look at maternal and fetal. So clinical, I would say the clinical outcome that I think is most relevant for the maternal patient is the reduction in red cell transfusions. And I don't think we need, or perhaps maybe some people still want to see some evidence or data outcomes that are associated with harms of transfusions, but I would indicate that we've seen harms associated with transfusions. So if we can reduce the number of transfusions, then that is direct harm reduction. As far as fetal and neonatal outcomes, iron deficiency and iron deficiency anemia is associated, doesn't necessarily mean causes low birth weight and has a trend towards preterm birth, and supplementing pregnancies with iron doesn't show a statistically significant difference in low birth weight, but the trend is there. So I would say it's not that there's an absence of benefit, but I think we haven't demonstrated a clinical effect. I don't think we've seen large enough data sets to say that there is no difference in a fetal or neonatal clinical outcome. The neurodevelopmental issue is quite interesting, and that one is really, really hard to demonstrate with data. Obviously it's going to be mostly observational data, but there is prospective data out of South America, which I did take that slide out of my presentation, but there was a 19-year follow-up from a South American data set that showed that it had two different groups of people. They had low SES and middle SES that was kind of vaguely defined, but anyway, they showed if you treat lower SES patients and children with iron, they have not as much of a decline in cognitive performance scores. So supplementing iron in childhood and elevating a child's iron level potentially could improve their neurologic performance and cognitive performance as a child and teenager. So and so I think that iterates the importance of iron supplementation and having iron available for the fetus, neonate, and child, as well as us having available animal studies that do show a direct impairment of myelination in iron-deprived rats. So we can see lower myelination, which obviously is going to impair neuro and neurocognitive performance. So
there's one last question that just came up in the chat that I know we're 1 minute over, but I think is an important clinical pearl for everyone to be aware of, and then we'll wrap up for the evening. Clarifying which lab tests exactly should be ordered for diagnosis of iron deficiency anemia.
Yeah, so first step, ferritin, because it's over 90% sensitive and 90% specific. So it's more likely to be falsely elevated because it's an acute phase reactant. So if you suspect someone is iron deficient and they have a ferritin above 30, then measure your transferrin saturation. And if it's less than 15%, that would also be diagnostic of iron deficiency.
Great. Well, thank you again to all of our panelists, and thank you again to all of our participants across the country, and to Ferring for providing the honoraria, which was generously donated by all of the participants to the University of Calgary Department of Obstetrics and Gynecology. Were there any other comments from any of the panelists as we wrap up tonight?
Just there's lots of questions of availability of the presentation, so it will be posted, and the slides will also be available so that people can get the information. And again, certainly, we're always, I think we're all able to be contacted if people have further interest in some of these areas. And very much appreciate everybody who participated tonight, did so voluntarily, and because we all care about maternal morbidity, and we really want to make a difference. And thank you again. Ferring did, make this happen. And, we have given the honorarium because we believe that we want to support projects that will enhance the care of pregnant women and women in labor. So thank you. And look forward to meeting you again virtually for the next topic, whatever it shall be.